Thank you. I'm going to talk fast. So I'm sorry. This is my disclosure slide. I'm not going to speak about anything today that is relevant to these disclosures. The topic I had today is data driving to regional centers? And so the first question we should ask is, why should we regionalize? How do we know it's a good thing? You know, the volume outcome relationship data, which has been very robust for many years, is really the driver for this initiative. I have to tell you that this is the very first study that reported volume outcome relationships in surgery, 1979. And you can see what it says here. We should not postpone delaying policies to encourage the regionalization of these procedures whose outcomes are markedly less satisfactory in low volume hospitals. So it's only been 40 years. So we've got lots of data and lots of evidence. But, you know, there's the association between quality and volume is actually pretty complex, and I think some of the data Jay showed earlier drills down to that. But the question is, where is the level of the interaction? Is it the surgeon level? Is it the institution level? What about surrogate procedures that count toward expertise? And I think the most important question is, how does quality improve? So before you can convince people to regionalize, you have to try to answer or address these questions. And just to show some data quickly, this is the volume outcome relationship. This is a seminal paper by Berkmeyer in 2002, which demonstrates volume outcome relationships. I highlighted the red one because I'm a pancreas surgeon, but that's really in complex cancer surgery, where some of the strongest volume outcome relationships were shown, particular in mortality. You can also see that in bariatrics, particularly for this audience, that there is also an volume outcome relationship that is both at the level of the surgeon and then also at the level of the institution, where you can see that physicians and surgeons and or institutions that have low, medium, or high volumes have an inverse relationship to the complication rate. I do want to point out that if you look at other markers of quality, so a center of excellence model, in fact, they did not see a relationship between volume outcomes if you use a center of excellence model to talk about quality. And I'll speak to that in a few moments. But there are actually detractors. So there are a lot of advocates for regionalization. The thought is that it probably works through this Donabedian model of quality, where regionalization or centralization works to look at structures of care. That's the infrastructure of care, including the training, the expertise of the surgeons, and also overlaps into issues of process. And it has been successful. I'm going to talk about an example in jurisdictions where it has been successful. I think Jay talked a little about horizontal integration, about hospital mergers as another way regionalization is happening. And we have seen improvements in areas where they have been regionalized. But there are lots of barriers, and I think 40 years where there hasn't been good uptake is part of we have to figure out what those barriers are. I would say that there is a lot of interest remaining in the surgical community for this. In fact, this is a multinational consensus conference that was just published last year, looking at North American, European models, and they really make a plea toward consensus in centralization, consensus towards centralization in surgery. These are the 12 recommendations. I'm not going to go through them all, but if I have a pointer here, I can show that, in fact, one of the things that they look at is that specifications for centralization must be legally enforced for adherence. Good luck with that in America, okay? So I think maybe I'll highlight that and speak to that in a moment, but I think there are some barriers that are quite large that may be challenging to overcome in different jurisdictions. But I would say there are people who don't believe that regionalization is the only way to improve care. One of them is that stuff just gets better over time. So this is an NIS, this is a national inpatient sample paper that was published late last year that looked at a sample from 2003, 2012. If you look at the high volume hospitals that's shown in blue and the low volume hospitals shown in red, that over time care is actually getting better everywhere. So you can see that although low volume hospitals, the perioperative mortality rate still is a little bit higher than high volume centers. Certainly this discordance that we saw in the early 2000s, the earlier publications, we're seeing that care is starting to get better everywhere, and that so maybe the drive to regionalization is not as high as it was previously. The other one is probably this has to do with other quality initiatives beyond regionalization. They have to do with system-level quality improvement initiatives. NSQIP is one, pay for performance, bundled care. Some of these other initiatives have helped reduce the spectrum of high volume and low volume hospitals in their care. And then there's also other models of care that don't look just at volume, but look at some of the structural elements. And these include accreditation models that the bariatric communities moved to, which is a voluntary model of accrediting centers of excellence that look at infrastructure. Volume is part of it, but not all of it. And that currently in the US, 88% of bariatric units actually already occur in accredited units. So even though we may not be regionalizing, perhaps we're meeting these quality standards in other ways. So, and that efforts in the U.S. to regionalize have been very limited, unfortunately. There have been a couple initiatives, Leapfrog and Take the Pledge campaigns, which look at trying to drive payers to pay to centers where there is meeting minimum volume standards. This is just the pancreas one, again, because this is my area of interest. If you look at this area, you can see that high volume centers only make up about 3.4%. And if you include people who are high volume once in a while, that's only about 6.7%. They take care of about 42% of patients, but that still means that 89% of institutions are low volume, and they take care of 40% of patients still. So it has been it has not been successful regionalization. And there is a knowledge to action gap. So this is the question I had. Does data drive to high volume center? And I would say no. I would say that data is essential for change, but it's not sufficient. Jay spoke about this a little bit earlier. There's both strategy and execution. I think the challenge that we have now has to do with execution. We got data, now what? So you need a plan, you need data and a plan. That plan can be any of those listed there, but you have to choose something. And I want to just say that part of it is that this is a translation gap between knowledge translation. The evidence has been there for 40 years. We're not there yet. And so how do we get there? I would say that it actually takes quite a bit of work. You know, data comes in here. You've identified a problem. Then you have to do all these things. You have to understand the context, understand the barriers, find something to do to fix it. Then you need data here to monitor it. You have to use data to evaluate it, and you really have to continue this cycle. And this is the knowledge to action framework that we used in Ontario to try to drive regionalization. And if you look at the consensus panel that was that was published by von Lanathan just recently, these are the barriers they talked about. I'm not going to go through all of them, just to say that there's barriers that have nothing to do with data or evidence in terms of medicine. They have to do with healthcare provider barriers, patient-level barriers, payers, and then political. So political decision is not enforced, regional differences, conflict of interest between societies, overwhelming bureaucracy, etc. So those are the kind of barriers that have to be overcome in order to take strategy or evidence to execution. I just want to give a quick example of Ontario. If I run out of time, you can cut me off, but the reason I put these slides in there is to show you how much work it takes to get from one place to the other, okay? So I was had the opportunity to be the quality lead in Ontario, and our portfolio included both developing, which was before my time, regionalization of complex cancer care, but also enforcing compliance, measuring it, and ensuring that it still worked. First of all, we had to come up with an idea of what that meant. So regionalization is not just central, not just, you know, so horizontal integration of hospitals sometimes leads to centralization without a plan. This one was a deliberate reorganization of cancer surgical services based on explicit and planned processes and structures of care with the intent. The intent was not to save money. The intent was to improve quality of care. So you have to have a plan before. I just want to say this is my organization, that what we looked at is we had the opportunity, single payer system, single payer insurance system, and that but it is a private delivery model, so I still think there's relevance to the American framework, and our portfolio looked at regionalizing complex cancer care as well as other quality initiatives. Before we did regionalization, there was a 14% perioperative mortality rate in a low volume group. And the readmission rate was almost 40%. It was a long time ago, but this is what happened before regionalization. So you need data here. And actually, you need data that actually doesn't look good, right? Because if your data is good, you don't actually need to do anything. So you have to have a gap that you have to fix. Then we developed with evidence. a panel that looked at this is what we're going to do. So we looked at our local context. We developed a strategy that looked at structures of care, including surgeon training, hospital infrastructure, required closed ICUs, required ORs, 24-hour days, IR, CT, etc. We had volume targets, which looked at more than 20 pancreas cases a year, which really is in line with the Leapfrog or Take the Pledge campaign. And then we had benchmarks. They had to meet these benchmarks. And then we had to do this. So we thought we were awesome, but this was only the beginning. Then we had to send out a market share. Regions had to submit information to us. We had to approve the plan, and then they had to agree to annual performance monitoring. And we were able to reduce the number of institutions that did the surgery from 68 to 10. As part of that, we then used data for audit feedback, and this is another place where you need to have data, compliance, performance management. So we looked at cancer-related performance as well as volume, publicly reported. We had audited them for case review if they were having issues. We also engaged the community with thought leaders to get clinical buy-in, to have face validity for what we were doing. And I think importantly, and I think this is the kind of thing that makes things work, is that we had some sticks too, including we had carrots, which were the money, and then we also had some sticks. So financial levers, even if they're modest, can make a huge difference. Some of the bundling that we're talking about allows you to do that. We took a modest amount of money, so only about $10 million initially, which is over a $500 million budget. It's very low, in order to drive some of these quality initiatives. And that it just got people engaged, got people to listen. Very modest amount of money leveraged for quality improvement to get the C-suite's ear. Then we had public reporting. We made the quality metrics so the institutions could reproduce them at an institutional level, so they could pull their own charts, look at their own information, and then we would review it with them. And with that, we were able to drive to be successful at regionalization. We were able to take, at this time, and I have to say that I'm very proud of this, that we look at both hepatobiliary and pancreatic surgery. 100% of pancreatic surgery is done in a jurisdiction of 13 million at a center of excellence. Okay. We also were able to look at our 30 and 90-day mortality rate. We have a 30-day mortality rate of 1.9%, 90-day at 3.5%. This compares to American data in the same vintage, which is double that. 30 days 3.7, 90 days 7.4. So this is where we go back and look at the data. And that compared to the rest of the country, we're also able to compare ourselves to the rest of the country here. We're below average. And this is a very elegant study done by one of my colleagues at the Canadian Partnership Against Cancer that really looks at, that reproduces that volume outcome relationship at a population level for the entire country of Canada. So basically, I don't think data alone ever drives change. You need data and a plan, and if regionalization to drive to high volume centers, you need to have both together. It was pretty painful, and it took time. It didn't happen overnight. It took about 5 years. We have to continually monitor it. Every year we have leakage. Every year someone tries to do a couple of cases, and we have to kind of talk to them about whether or not this makes the most sense. And the data also maintains momentum, highlights success, promotes compliance. And I think you can't be successful without addressing the barriers to regionalization that are there. And you need both carrots and sticks, and I think there's carrots and sticks that are different jurisdictions, but you need both of them to be successful. Thank you.